with the atrium situs. From the downward, you can see the orifice of the IVC, and also you can see the apex here, which is broad-based and a bit like triangular shape, which makes this ventricle, which make this space the right atrium. And on the other hand, you can see this chamber here with a very narrow-based apex with less pectinate muscles, and this probably is the left atrium. And for the ventricles, if you open it up, the one that's connected to the right atrium has this, you can see this valve, and the apparatus that's attached to this valve only reaches to the free wall. It doesn't have any attachment to the septum. And the one on the left, you can see one apparatus reaching to the septum, which makes this morphological right ventricle. And this is the tricuspid valve. And the chamber that is connected to the right atrium is morphologically left ventricle. So this patient has AV discordant. And for the aortic arches, if you look at the one coming from the morphological left ventricle, first we thought this was the coronary sinus. You can see here there are two orifices, which we first thought is the orifice of the coronary artery, but it's a bit too big and high from the valve, so we thought this may be the pulmonary artery. And
at first we referred this orifice as a coronary artery, but it is rather big, and we confirmed that this is the bifurcation of the pulmonary arteries. Okay? But we should find the orifice of the coronary artery, origin of the coronary artery, to define the ascending aorta operating from the ventricle.
Okay. So if you look at the ventricle from the outside, you see a little structure running down, and this probably is the coronary artery. And you look from the downside, it's very difficult to define the orifice of the coronary artery, but you could probably see a very, very tiny orifice here. This probably is the orifice of the coronary artery, which makes this the aortic arch, and this one here, the pulmonary artery. So the diagnosis is corrected TGA with probable...
With a closer look, there's a very difficult to find the origin of the aorta, but very narrow valve inside, right here, the aortic tract. Transept. Is it allowed? I think it is a very important specimen. Okay. So we find the bicuspid or narrow opening of the aortic tract right here, and we can. But we find difficulty to find the orifice of the coronary arteries. But from the outside, we find this like the coronary artery right here, very small. Okay, it's just right. Okay. This is the orifice of the coronary artery. So tiny. Maybe right here. So we've confirmed the diagnosis as the congenitally corrected TGA with a relatively large VSD and AV discordance and VA discordance with aortic stenosis, very severe form of congenital heart anomaly, which resulted in the death in the soon after birth.
Okay, so let me move on to the second case. So starting with the atrium again.
let's begin with the
Yes.
atrial situs.
Atrial situs. So you can see the orifice of IVC here, and this probably is the appendages. It's a broad-based and bit triangular shape, so this makes this right atrium. And on the other side, you can see more finger-like shaped, narrow-based appendages. So this is the left atrium. And for the ventricles that are opening to it, on the right side you can see two apparatus on the valve, only reaching to the free wall and none to the septum. These are the two apparatuses.
You can also see right here the patched,
Yes.
repaired interventricular communication. Okay. On the other hand,
And on the other side, at first we thought the endothelium was very smooth, so we thought this could be the left ventricle, but we weren't sure about the apparatus of the valves. It was very difficult to define, but on the apex side you can see trabeculation, so we thought this could be the atrium and Epstein morphology.
okay. At first, we suppose that this smooth, fine structure of the may be the endothelium of the left ventricular morphology. But with a closer look, we can see the curtain-like deformity of the valve structure right here. So we confirm that this valve morphology is an epsinoid malformation, which can accompany with the congenital corrected TGA about 40 or 50% incidence.
From behind.
From behind.
To open from the atrium to left atrium to ventricle.
Okay. Right here. Okay.
Yeah.
Thank you.
Yeah, so that's how. Yeah, this is tricuspid valve displays downward. Epstein.
You mean this? This is the plastering of the septal leaflet right here.
The altogether tricuspid valve is displaced almost to the apex, so
Okay.
Epstein is very severe. And
Yes. So very severe deformity of the epsinoid malformation.
Okay. So from
Yes, left side is the system ventricle, yeah.
So this is the initial systemic ventricle,
Yes.
morphological right ventricle, okay? And this has the, we
So
can clearly
you can
see.
see the orifice of the coronary
Artery.
arteries. So this is the aortic arch, ascending arch.
ascending aorta, and we can see right here the origin of the ascending aorta from the morphologically right ventricle and systemic left ventricle.
Yes, yes.
And
The morphology of system left ventricle, functioning part of our systemic right ventricle, left side is the system right ventricle is very small.
yes,
Yeah, very small. So the systemic perfusion is not made from that left side system right ventricle previously. Just through the ventricular septal defect made the channel to the aorta.
we suppose that this morphologically left ventricle has an adequate size, and we have no idea this is functioning or not. But definitely, this pulmonary artery arises from just right posterior to the original aorta. So we confirm the relationship of the L-loop congenital
Sure, I
L
agree.
transposition.
Yeah.
So we thought this VSD patch closure is intended to not anatomical repair, but physiological repair to close the shunt.
But because the right ventricle is not normal and the left side, the tricuspid valve has a severe anomaly of stenotic abstain,
Yes.
malformation. So after closure of VSD, the left-sided right ventricle cannot pump at all to acquire the systemic perfusion.
So
So this is the cause of death.
yes.
Yeah.
So this morphological tragus valve, in other words, systemic valve has a severe regurgitation. That operation is not, will not successful. Okay.
It's a stenosis, not regurgitation.
Oh, it's noted.
The stenosis and malformation do not usually have a regurgitation much.
So, by the way, so how about the preoperative condition on this patient? Because antegrade flow from the left side all the way to elbow. Was it reasonable volume or flow or not? Yeah, because after closure.
Very far away from now, almost the 1980s something. So it's not physician of that patient, but that patient has a functioning single ventricle with a right-sided left ventricle, and that left ventricle pumps both direction to the VSD aorta and another way to pulmonary artery.
So this is a case of severe confusion by the clinicians. So the clinicians understood there is a part of functioning systemic ventricle on the left side, morphological right ventricle. But so they thought it's possible to make a biventricular repair by making VSD closed, but it's totally wrong decision to close the VSD. So it's almost 25 years ago specimen when the clinical examination was not enough at the time.